right, today we're going to talk about antihyperlipidemic agents. That's a really big word, antihyperlipidemic. To say, if you have hyperlipidemia, you have high cholesterol. So these drugs can lower your cholesterol or lower your patient's cholesterol. And what these medications are designed to do are delay or prevent the first event caused by high cholesterol, like a heart attack or a stroke. We're going to delay that heart attack, prevent that stroke. So we're preventing or delaying the first event. Your patient might be prescribed these after the first event, so we didn't catch the run up to the first event, but that heart attack or that stroke happened, and we're going to prescribe these cholesterol medications to prevent or delay additional events. So overall, your patient is on this medication or these medications to decrease overall mortality. Because what happens when our cholesterol goes higher and higher and higher, especially our bad cholesterol goes higher and higher and higher, right? That's when we start getting this plaque and these little fats building up in our vessels and our arteries, right? And this is going to lead to, as we decrease that lumen size, decrease to, or lead to a decrease, there we go, lead to a decrease in oxygen supply when our, maybe our cardiac cells are needing that demand, or our cerebral cells are needing that demand, so supply is diminished. Then I have that stroke. Then I have that heart attack. So we need to control cholesterol, and if we can catch it early, then we can prevent and delay that first event. If we don't catch it early and that event happens, then we can prevent, delay an additional event. So with all that, let's talk lipoproteins or lipoproteins, depending on who you talk to. But let's talk about these proteins. Is a lipoprotein? Well, it's a protein. It's a protein shell that surrounds a lipid core. And we need lipid circulation within our blood, and these are responsible for circulation within our blood. And we're going to classify these different lipoproteins according to their densities. So we have a lot of different lipoproteins circulating through our blood. Some are good and some are helpful. Some are not so good and not so helpful. So we're going to classify them, and they're classified based on the density of the lipoprotein. Based on their densities, we have VLDLs, or very low density lipoproteins. We have LDL, low density lipoproteins, and we have HDL, which are our high density lipoproteins. Our HDLs, our high density lipoproteins, are our good cholesterol. It's what we're going to call, what we typically call good cholesterol. So our HDLs actually contain a very small amount of cholesterol. They are there to transport cholesterol from our peripheral tissue to our liver, so our liver can excrete it. So they're just kind of these like little transport buses. Um, this is our good cholesterol, and high levels of HDL are considered good and beneficial because there are little buses that take the cholesterol to be flushed out of our system. So more HDL we have, the better, kind of quote unquote, it's said to be. The VLDLs are very low density lipoproteins, and these are mostly triglycerides. So if you break them apart, what are they transporting? Primarily triglyceride, and then about a quarter to a third of it is cholesterol. Makes up about less than 20% of total body blood cholesterol. So really large molecule because it's a very low density lipoprotein. So the lower the density, the larger the molecule actually is in size. So very low density. Not a huge player in forming these plaques and these clots, but we do need to keep an eye on them. That's because our VLDLs are going to turn into our LDL cholesterol. Our low density lipoproteins are bad cholesterol. So our VLDLs Once the triglycerides are taken out of them and removed from them, they become LDL. And our LDLs, this is our bad cholesterol, kind of quote unquote, our bad cholesterol. This is most of our blood cholesterol, and this is the harmful one, right? So our low density lipoproteins are kind of big molecules, and they're the ones that are going to create. They carry a lot of cholesterol. So these are the ones that are going to form that plaque and going to form those clots in our vasculature. So the higher your LDL, it's pretty bad. But the higher your HDL, it's pretty good. So LDL is bad. VLDL, we're going to keep an eye on it because it turns into LDL. But LDL bad, HDL good. Now we have an issue. We have a problem with our cholesterol. And when we say we have a problem with our cholesterol, we have hyperlipidemia, typically talking LDL. So my LDL is too high. What are we going to do about it? First stop is going to be lifestyle changes. Exercise more, change your diet. That is the first stop. And that typically works as long as the patient is adhering to diet and exercise recommendations. Lifestyle changes work really well. If they aren't working, or the patient for some reason can't adhere to it, right, we're gonna go down the drug therapy route. Then we're gonna go to medication. So first stop is lifestyle changes because they're pretty. This is a non-invasive, non-medical medication route, and if you just go on a few walks, go for some bike rides, go to the pool, change your diet, we can lower your cholesterol. If that's not working, then we'll give you a medication. Becomes, if we're going to give you a medication, what medication are we going to give you? And we've got four broad categories, broad types of cholesterol medications. First of which is your hydroxymethylglutarate coenzyme A reductase inhibitor, and those are really, really long medical mumbo jumbo stuff. So your HMG CoA reductase inhibitors are your most common. Well, we're going to hit all of these in succession, but those are your most common. Then we've got niacin, we've got fibric acid derivatives, and then we've got that last one, ezetimibe, which is another fun word to say. So four broad categories, but that first one, your HMG CoA reductase inhibitors, is the most common. Let's hit these HMG CoA reductase inhibitors first. They're derived from fungi, right? They're mushroom derived. they're naturally derived from fungi plants. And what do they do? Well, they decrease LDL and they decrease VLDL. So they're directly decreasing bad cholesterol, and then they're indirectly decreasing bad cholesterol by decreasing VLDL, because remember, VLDL are very low density lipoproteins. Once we take the triglycerides out, they turn into LDL. So we're both directly decreasing bad cholesterol and indirectly decreasing bad cholesterol. On top of that, these medications increase HDL. So they increase your good cholesterol, they decrease your bad cholesterol both directly and indirectly. So you see why they're the first stop typically and the most commonly prescribed cholesterol drugs. These are going to be our statins, and you'll hear them just broadly referred to as statins. And that's because these drugs end in statin. So, atorvastatin, lovastatin, pravastatin, simvastatin, they all end in statin. But you probably know them better by their trade names because there's been a lot of marketing and advertising behind these drugs. Believe you me. So, Lipitor, Pravachol, Zocor, and Crestor, very, very commonly prescribed drugs. Um, But these are all of our statins, and they are all these HMG CoA reductase inhibitors that decrease LDL and VLDL and increase HDL. Moving on from our statins, another type of cholesterol drug is niacin. Niacin is just vitamin B3, And you can get this over the counter, not in prescription form, or prescription strength, I should say, but you might see niacin or B3, you know, in the vitamin section at CVS, but that's not quite the amount that's being prescribed when used for cholesterol control. But niacin is vitamin B3 and it decreases VLDL and increases HDL. So it's decreasing bad cholesterol, but it's decreasing bad cholesterol indirectly by decreasing VLDL. And it's just like our HMG CoA reductase inhibitors, it is increasing HDL. Like I said, niacin, we can go and pick that up off the counter, over the counter, off the shelves. And the cholesterol effects. If we want to lower cholesterol, those are very dose dependent because we get niacin, we get this B3 in our normal diet. I take a multivitamin every single day, and there's niacin, there's B3 in that multivitamin. So, am I lowering my cholesterol by taking that multivitamin and just my diet, which has niacin in it, has B3 in it? No, right? It doesn't really have any effect on my cholesterol. To get to that effect, we need about 2,000 milligrams, a couple grams every single day of niacin. That is a lot of niacin. You're going to be going through a lot of bottles of B3 if you buy it over the counter. So do not go to Walmart, do not go to CVS and just pick up a bottle of vitamin B3 because you think your cholesterol is a little high. This is a prescription strength niacin. You are being monitored by a physician. So, yes, you can get it over the counter. No, do not take 2 grams of niacin per day unless prescribed by a physician. So, our third category of cholesterol medications are fibric acid derivatives. These lower triglyceride levels inhibit secretion of VLDLs. So we're focusing on lowering VLDL, focused on lowering triglycerides now. So these don't increase HDL. They focus on triglycerides, focus on VLDL. The most commonly prescribed of these is Lopid, not as commonly prescribed as it once was, but if you see Lopid, that is a fibric acid derivative and used to lower cholesterol. This one we're going to talk about for controlling cholesterol is ezetimibe, and this isn't really a category of medication. It's a medication in and of itself, and this is the generic name for it. It inhibits absorption of dietary cholesterol. So you take in dietary cholesterol by whatever you eat, drink, and this medication inhibits the absorption of it. On top of that, it lowers your LDL and is typically used alongside, or was used alongside, statins because it's very synergistic with statins. So its primary purpose is to lower LDL and on the front end just inhibit absorption of cholesterol to begin with. Say it used to be used synergistically with our statins because our two medications that you would have seen, hopefully you don't see them anymore, but would have seen, trade names are Zetia and Vytorin. Both of these drugs went on the market, and a number of years later, they got some data in, and people started dying of heart attacks and strokes, and saw a huge risk for heart attack and stroke when taking these medications. Both have been pulled from the market, but if you ever hear of them, that's why we're throwing this in here today. You might hear of them, might hear of Zetia, might hear the name Vytorin, and that's what this medication was. So it was developed, had a really promising future, and then the long-term data didn't quite prove everything correct. Overview of our cholesterol drugs or antihyperlipidemic medications. Which one do we give? Well, it depends on what you want to control. Well, we want to control cholesterol. Well, how do you want to control it? Is our question. So, do we give a HMG CoA reductase inhibitor? Well, that's where it's going to work right up there, right? So it's going to lower VLDL, going to lower LDL, going to increase HDL. Do you want to give, niacin? So we can give niacin to increase HDL, decrease VLDL. We can give ezetimibe. Um, you never want to give that. You don't want to give Vytorin, right? Don't give Vytorin. So we have our statins, we have our niacin, and we've got our fibric acid derivatives in there as well. So it is just we have a common goal, but how do we need to get to that end goal? How do we want to get to that end goal? So overview: good cholesterol. What is good cholesterol? What are we going to call that? Good cholesterol is HDL, high density lipoproteins. Our bad cholesterol is our LDL, our low density lipoproteins. Our HMG CoA reductase inhibitors. Those are our statins. Remember any of our statins, or Lipitor or Crestor, any of our statins. We can give niacin, and niacin is also vitamin B3, just if we're giving it for cholesterol control. We're given very large doses, and those have to be prescribed. We're not just picking them up off the counter of Walgreens. We have fibric acid derivatives to control cholesterol. Those are going to focus on triglycerides and focus on VLDL. Most common of those is lopid. And then we have ezetimibe or Vytorin or Zetia, which has been taken off the market. But you might hear its name and maybe see it on a patient's counter. As always, if you have any questions, comments, concerns, or cuss words, let me know.